All right, I think it's on me then. Hey all, so welcome to SOCAC's Program and Policy Committee. I'm Leah Tucker. I use she, her pronouns, and I am the co-chair for this committee with Ebony Clark, who's OHA's Behavioral Health Director. This is the June 24th meeting of the Program and Policy Committee, and this meeting is being recorded and will be posted on SOCAC's YouTube channel for easy public access. First, we'll start with roll call for the voting members of this subcommittee. Then we'll review our group agreements for this meeting and then get an overview of the agenda. Then we'll move into the actual content for today. Ebony, did you want to do roll call?
Yes. All right. So I will, hello, good afternoon, everyone. I will read the names two at a time to leverage time. And I ask that when your name is called, please let us know if you're present and let us know your pronouns. If I miss anyone, please feel free to raise your hand or drop your name and pronouns into the chat. So to get started, Sonia Little Deer Evans and Courtney Esperanza.
Present. Courtney Esparza.
And I don't see Sonia here yet.
Okay. Lacey Anderson and Corinne Hell. No. Okay, moving on. Selby Stebbins and Nate Latazanio. Zio?
This is a good
No?
try. Here, Nate Latanzio. Thank you.
Okay, thank you for your grace. I'll get it right next time, I promise. Wes Rivers and Chelsea Holcomb.
Chelsea's excused, as is Selby. They're both out of office.
Molly Haynes and Emma Sando. Well, Emma's on leave, I know that. So is Meg Carey here as her proxy? I don't see. No, okay.
I think we skipped Remy though. And I
Oh,
do.
did I? Oh, it's my. Okay, so I'm having issues with my view. Okay. So yeah, someone named Remy did it. My bad. The name's not showing up on my screen.
Hello, Remy Watts, she, her pronouns.
Hi,
I'm
Remy.
here. Thank you. Nowhere, Ebony, it's so good to have you here or to talk to you. It's good to see you. Thank you.
Thank you. All right, so we have Lydia. Is it Lydia Fluger? And Jerome, is it Jeremy Buchanan? Okay.
I don't see either of them in the list either.
No. Jared Hayes, Debbie Martin.
Hey, Jared Hayes is here.
Okay. Anna Day.
Hi, Debbie Martin's here too. Hi.
Okay, hello. Okay, then we'll go to Anna Day and Monique Turner.
Yeah, I'm here, Anna Day.
Oh, hi. Thank you. Sorry. This is good because I will be held accountable to pronounce names correctly next time. Thank you for your grace.
It's tricky with Anna Williams.
We have Alex. Thank you. Alex Salas and Christy Reese.
Alex here.
Alex, how do I say your last name? I'm sure I messed it up. I'm sorry.
I don't know. You got it good. Great.
Okay. Thank you. And Christy's here.
I do see her on
Yes, Christy's here.
Thank you. Brian Detman and Emily Lamson Sue.
Emily, I'm here.
All right. And Emily, did I say your last name correctly or how do I pronounce it?
You did.
Okay, thank you. All right. Did I miss anyone? All right. Well, Leah, I'll hand it back to you.
All righty. Oh, sorry, I need to find where I'm at today. So we'll do the Sorry, I need to go back. The group agreements and acknowledgements. So SOCAC acknowledges the harm and systemic oppression of historically marginalized groups at the hands of Oregon's governmental institutions and system partners. These systems include education, child welfare, criminal justice, health and disability services, and other systems where an overrepresentation of marginalized populations exists. Of particular concern are Black and Brown families of historically marginalized communities, LGBTQ plus youth, and tribal children and families. Program and policy committees group agreements, be present and participate to the best of your ability, treat others with respect, avoid interrupting and using the name or pronouns they prefer. Avoid acronyms, use the chat to write definitions or ask for clarification. Varied and opposing ideas are welcome. Be curious when disagreement occurs. Honor those with quieter voices, lean in or lean back. Avoid problem solving for individual situations. Connect offline if possible. Focus on our purpose, improving the system of care for Oregon. Be mindful of power dynamics in the room. Do your best to avoid harming others. Be open to repairing harm you may cause. Our main goal for today is today's meeting is to hear about SOCAC's work to scope and define barriers to school-based services and supports and discuss next steps we should take across the children's system to resolve these barriers. We'll end with a public comment and some preview information about the topic for July's meeting. Christy Hudson, is she? Yes, she is. I see her now. SOCAC's transformation manager is here to share a policy brief. She's crafted with a lot of support from a variety of subject matter experts, including lived experts regarding access to school-based services and supports. She'll present for about 30 minutes and then we'll have about 30 minutes for a large group discussion. Christy, that means the floor is yours, which means Anna, you need to stop sharing, I believe. And did we give Christy sharing rights?
I do. It looks
Okay,
like
cool. Perfect.
controls. Great. All right. Well, thanks so much. Really nice to see you all. I think I have met everyone here, but if we have not been in a space together, my name's Christy Hudson, she, her pronouns. I am transformation manager with the System of Care Advisory Council. And here today to really start a conversation about what we can do to dissolve and address barriers related to accessing school-based services and supports. So I've got a number of slides. I'm definitely not a subject matter expert here, looking at all you in the room who do this work every day. So please, like, this is a conversation. I'm going to miss stuff. I really look to you all to help, correct, add, lift up. We could probably spend a month talking about this, and we have an hour and a half today. So this is really the start of a conversation, really hoping to orient everyone in this committee to how SOCAC is wanting to approach this work. And hopefully by the end of today, we'll have kind of an idea of a next step that we can take. So let me get my slides up. There are a lot of acronyms in this work. I am bound to use them. I went through and made myself lots of notes, but really, please give me some grace and help me out if I use an acronym that you do not know. And then finally, before I get started, I have a gaggle of sweaty soccer tweens that just arrived at my house. So I left out snacks, but hopefully they won't interrupt me. If they do, I apologize. Thank you for the grace. Okay, so like I said, today I really hope just to orient people to the concerns and opportunities that we have heard over a very long number of, lots of time about improving school-based services and supports for youth with complex needs, and to identify some potential next steps that SOCAC's Program and Policy Committee could take. I think in particular, really encourage you all to think about where System of Care as a structure, as a council, is really uniquely positioned to address gaps. There's a lot of things that are already happening that are great. And where can we address gaps, leverage those things? Where do we really bring some unique value into improving the system? So as it relates to our strategic plan, right, that is really grounding all of our discussion. The particular action we're talking about is action 1.2.2, implement more school-based supports and services for students with disabilities This lives within Goal 1, Strategy 2. So within Goal 1, about improving access to coordinated, integrated, community-based systems of care, and within that Strategy 2, breaking down barriers to better coordinate, integrate, and promote community-based care. Why is this important? I'm not going to spend a lot of time on the data. You all know the situation, but just, to take a minute, right, to really ground us and why we're talking about this particular thing, why this is the priority. Number one, this has consistently been elevated as an area of concern by family members and youth. We heard this very loud and clear throughout all of our strategic planning process and even before. We also know that schools play a really important role in the lives of young people, given how much time they spend at school. And that while they're there, they have access and exposure to supportive, skilled adults, and we know what an important protective factor that is. I also want to note and celebrate the work that our local systems of care partners do in this in terms of barrier identification. This is something they often report in those 6-month barrier reports that they are providing to OHA. And then again, there's a lot of quantitative data that we could look at, but just to bring forward, one of the key indicators we're using for our strategic plan is around completion of high school within 5 years. This is one of the measures we're looking at, obviously a really important measure in terms of longer term outcomes for youth. And as you can see very clearly, youth with disabilities and youth with system involvement have a harder time completing high school within 5 years. And we know these inequities really persist across many other data points. So all that being said, SOCAC, based on all of the work that we did around the strategic plan, has identified 3 areas of opportunity. So again, this is not exhaustive. There are a lot of other things that we could be talking about, but based on what we heard from youth and family, based on what we saw in the data, these are the 3 areas that we'd like you all to think about today. The first is related to timely and coordinated access to assessments and valuations across systems. So thinking about the things that happen around getting a medical diagnosis, thinking about what happens to determine eligibility for special education, thinking about eligibility processes for disability services, right? There's lots of things that youth and families need to do to kind of access publicly funded services. It's really overwhelming. There's a lot we can fix. The second area is around implementation of behavioral health supports and services in schools, including IEPs, individualized education plans, and 504 plans, not limited to those things, right? But really what is happening within the school, within the classroom, within that building. And then the third area we're going to explore is around coordinating with community-based services outside of school. What do those relationships look like? How are people integrated and really working together to help youth and family? So we'll dig a little bit deeper into each of these areas. Again, please, if you've got something to add that we're not talking about yet today, please raise your hand. And I can't really see the chat or anybody, so
I'll holler it out if people put
Ebony
anything in the chat, Christine.
Okay, that would be great. So we'll spend a little bit of time. I'm going to spend a little time talking at you, and then we're going to have some time to move into some breakouts for you to really think and talk more about these areas. So the first, timely and coordinated access to assessment and valuation. Again, we're talking about what that looks like in a variety of systems. Children with disabilities and related behavioral challenges may be eligible for a variety of treatments and services, but families face barriers in accessing assessments and evaluations across systems, and the lack of coordination is very complicated. Within the medical system, well child visits provide early intervention opportunities for primary care providers to screen and evaluate for disabilities. However, a lot of youth aren't getting to their annual well child visit. According to CCO data, Medicaid services, only 70% of 3 to 6-year-olds had a well child visit in the past year, and this drops. The percentage decreases as kids get older. We've also heard that a lot of primary care providers, pediatricians, feel unprepared to diagnose for some conditions, especially as children get older. And so when a pediatrician or provider isn't totally sure what's going on with a child, they'll often refer to specialists, and then we've heard that those can be very lengthy wait lists. Sometimes up to 2 years when referral is made, especially after early childhood. So services and providers within the medical system are just not keeping pace with increasing disability and behavioral health challenges that we're seeing. Within the education system, again, different assessments are needed to determine eligibility for special education like IEPs and 504, but not all children with a medically identified disability will be found eligible for special education. And then thirdly, youth with an intellectual or developmental disability like autism or ADHD may also be eligible for services provided through the Office of Developmental Disability Services, which maintains its own procedure and process and policy for determining eligibility for services. And again, not all youth with a diagnosed disability will be found eligible for services. So you can see the confusion and frustration that this creates for families. Pathways are burdensome, confusing, especially when eligibility criteria differ and schools and community providers aren't working in coordination to identify the services a youth may be available for. That's a lot. I'm going to pause. I know we've got a number of subject matter experts around this particular topic. Is there anything else people want to add at this time?
This is Christy from FACT. I just want to
Hi.
add that DD services, ADHD is not an eligibility for DD services.
Okay, great. Thank you for clarifying.
This is Alex. Oh, sorry, I didn't raise my hand.
That's fine.
Oh, okay. I just want to clarify too, is when we talk about case management, are we talking about through the Medicaid system or as a standalone service? What's the clarification system wise about how case management would in this realm? I guess I'm a little confused on my own question, as you could tell.
Like where is the case management system for all of this?
Yeah. If it's needed, where is it being provided? Is it only through eligibility that they receive case management? Because what sounds like we're talking about is case management support to gain eligibility. And I think those are two different realms and two different frustrations from families.
See, Chrissy's got her hand up.
So in each of these entities, there are different folks. So, and there's not one coordinated system. So in education, you will have a case manager who handles the IEP or 504. In DD services, you have a services coordinator if you're a child, and then medically within your own medical place, but none of those actually are connected or talk to each other.
Interesting. So there's not some overlapping like traditional health worker or peer support service unless they're connected to behavioral health supports in an outpatient way that could provide overlapping coordination or maybe wraparound coordination, but still the technical aspects and difficulties between those two realms and understanding DD eligibility is far gone. And that's the kind of gap we're talking about, just for clarification.
There's often if a family originates it or if the educators are familiar, there's attempts to do that, but it is not an automatic.
And there is no specific rule set, Alex, that governs that. So it's not like for all kids in this space, they would fall under the Medicaid complex case management rules or anything like that. Like we could make that as a recommendation as we continue down the road on this work if we felt like there was a rule set that was appropriate to govern it. But right now, to Christy's point, it's sort of like if somebody decides to do it, how they decide to do it is how it happens.
Amazing. Okay. That's so helpful on the framing of this. I appreciate the time.
Jared?
Thanks. I just want to echo what Christy had just said. If there is any kind of coordination, it's kind of what Christy's talking about, but it takes a lot of energy from the families, the educators in the school, the DD caseworker to try to sync this up. And they all are, have complex lives within working with the students on various levels. So it's to case manage on top of what all of those people are doing as stakeholders for the families and the students. It's like really hard, including the families. So there's sometimes we do kind of mimic that and have a model like, hey, parents are on board, DD caseworkers on board. We haven't had a lot of turnover with, say, a DHS caseworker or DD caseworker. and we're able to get some momentum. But it's someone at the school or the family or coordination that's basically quote case managing, which you can imagine is not ideal.
Mhm. All right, Remy, and then I'm gonna keep us
Okay, you can
moving.
see Remy. All right.
Yeah.
Oh, hey, thank you. I was just going to say it's difficult because I mean, y'all probably all know this, but from the state, like from ODE perspective, um, school districts all have local control and local autonomy, right? And that feeds into the problem of case management that you're talking about. And there are 197 school districts in Oregon doing their own thing most of the time. And it's really hard because FERPA, which is like the education version of HIPAA, is very scary for school districts. And they're so scared of FERPA laws that they will push away data sharing and like agreements with ODDS offices and make and create barriers to case management, which is something that we're working on at ODE, is trying to develop best practices around like, you know, working with these laws and also working with case management and letting people in. But yeah, I just wanted to give a little bit of context to like why it's difficult to elevate a best practice of supporting school districts in being more open with case management services. So yeah, it's really difficult. But I'm happy to have this conversation because this is something that we're working on actively and we can actually make a lot of change on in the next few years. So I'm happy to be here. Thank you.
Excellent.
great.
Super helpful
Yeah.
to know, Remy. And then Christy, I want to call your attention to Hillary and Leah in the chat as well. before we
Yes,
move on.
yes. This is great. You all are touching on things that we are going to be talking about. And yeah, you're all on the right track, which is wonderful. Okay, I'm gonna keep us moving because we got a lot to talk about. So I just want to pause for a second. So as part of kind of preparing for this conversation and the work that this committee is going to do, we held a focus group with the SOCAC's Family Advisory Committee a couple weeks ago. We had great conversation. And so I'm just going to bring forward some of the themes that were shared in those listening sessions. And Leah, if I've missed anything, please let me know. There's a lot more than this. But again, just want to stop and pause and make space for what families are sharing with us directly, which is that there are delays of sometimes years before receiving a diagnosis. It's very difficult in obtaining referrals, especially to specialized services. They're often repeatedly retelling their child's story across systems. Providers are dismissing concerns or recommending families a wait and see approach. School avoidance is a barrier specifically around getting an educational evaluation for special education. And in general, assessment processes don't take into account for trauma, anxiety, and neurodivergence. Okay, so in terms of actions, you've already started to kind of bring some of these forward. And there is actually quite a lot of opportunity in this particular area that we could build on. The first, to address barriers related to workforce capacity and confidence, we could leverage programs like the Autism Assessment Capacity Project, which is, I think, funded through HealthShare and is training providers to diagnose autism in early childhood. There's also services like Opal K and DBP, Developmental Behavioral Pediatrics, run by OHSU, to support providers who have questions about their patients. We can assist them. There's fellowships for pediatricians and child psychiatrists that could be expanded on. There's a lot more that we could do. Within early intervention, again, there's a lot happening here. Lots of opportunities within EPSDT and that Medicaid benefit, early periodic screening, diagnosis, and treatment, I believe. Certified community behavioral health clinics are also expanding across the state, and they are also required to provide access to screening and diagnostic services. The Department of Early Learning and Care has a new program called the Every Child Belongs program. That part of that is around early childhood mental health consultation, primarily targeted towards, I think, early childhood settings. But again, really a nice opportunity to try and identify children younger. The Oregon Screening Project is an online portal. Anybody can go there and really kind of use that to help identify, child developmental milestones. Ocean's Access Program, assuring comprehensive care through enhanced service systems for children with autism. This is a really cool program that is actually bringing medical and educational experts together to determine diagnoses for autism and educational eligibility. Currently only available to those under 5, if I'm correct. But I think a really interesting model that could potentially be expanded to older kids, home visiting. Lots of opportunities here. Consistency and coordination across the systems. You talked a little bit about like, what does care coordination look like for this? Is there one person who could just help a family navigate all of these things? Are there policy changes or system changes to streamline assessment and the eligibility determination? Could we just define and use process descriptors consistently? So when we say screening, when we say assessment, when we say evaluation, we're all using the same definition, understand what that means and the differences. And then finally, just information, public awareness, really like bolstering and leveraging the work that organizations like FACT Oregon are already leading. Okay, so lots that we could talk about there, but hopefully that is enough to kind of get you excited about that particular topic. Moving on to the actual school setting and only talking about K through 12. We're not talking about early childhood today. That's probably a whole other conversation. But for the sake of today, thinking about K through 12 public education and how those schools and districts are implementing behavioral health supports and services in schools. Oregon's Department of Education utilizes 2 complementary frameworks related to behavioral interventions for students, positive behavioral interventions and support, or PBIS, and multi-tiered systems of support, or MTSS. MTSS is an organizing framework that supports all students, not just those with identified disabilities. PBIS is an individual intervention that lives within the broader MTSS framework. Both PBIS and MTSS refer to 3 tiers of support. Most relevant to system of care would be Tier 2 and Tier 3 services. I've got a visual on the next slide I'll show you in a second. According to the Center on PBIS, which is actually located here in Oregon, it's a national kind of training and technical assistance center, 1% to 5% of students require Tier 3 supports to improve behavioral and academic outcomes. Despite evidence and use of PBIS in lots of other states, its application is pretty limited in Oregon, in part due to criticism that it reinforces inequities, especially along race, language, and disabilities. MTSS is also limited in application, and Department of Education has yet to develop rules or standards for use of either of these frameworks in Oregon school districts, although it's incorporated into ODE's new strategic plan, and there are some school districts that are using PBIS and MTSS. And then there's special education, of course, federal law, Individuals with Disabilities Education Act. It's there, and the implementation of it can be challenging. A 2020 audit in Oregon from the Secretary of State documented several areas of concern in relation to the delivery of special education supports, and they highlighted barriers in funding, workforce, and policy implementation. Funding is a problem. There are about 14% of all school-aged children in Oregon qualify for special education services. However, Oregon's special education funding gap is set at only 11%, which creates unfunded mandates for schools. And workforce is a problem. There's a shortage of special education teachers, educational assistants, and while movement towards inclusive classrooms is to be celebrated, teachers need additional training and support to ensure that the needs of all students in their class are being met. Aside from teachers, workforce shortages within staff at schools are another challenge for implementing these frameworks. We're far behind meeting recommended ratios for school counselors, school psychologists, social workers, and school nurses. Despite all of these ideas and frames, when these prevention efforts fail and de-escalation strategies fail, dysregulation often leads to behaviors that require disciplinary action. And this can look like room clears, restraint seclusion, in-school suspension, out-of-school suspension, exclusionary discipline. There are safeguards, especially for kids in special education to prevent exclusionary discipline, but we know that there are inequities for Black and Brown students and students with disabilities. And often in the face of inadequate supports, a lot of families feel pushed out of public school and opt out for homeschool or online options. Okay, I said a lot. Anybody want to add anything here?
There's quite a bit in the chat.
Okay, thank you. What did I miss? Oh, thank you for the acronyms. Links to MTSS, not widely used, correct. Calling out numerous school community mental health partnerships. Yes, ton of community-based providers that provide tier 2, tier 3. Thank you, friend. We're going to talk about that in a minute. Our systems reinforce system interest in behavior issues and not mental wellness. Okay, yes. Concerns for MTSS and PBIS. Yes. Okay. Again, this is the MTSS framework. It feels like people are familiar, so I'm just going to keep moving. But if we want to reference this, it's here. Again, what family members shared is that they had experienced failures with the implementation of the IEPs and 504 plans, that they were experiencing exclusion rather than increased supports, that behavior management emphasizes compliance, rewards, and punishment, and that school-related trauma comes in the form of restraint, seclusion, and forced attendance. Christy.
Thank you. I apologize for interrupting. I am compelled to share that when we talk about inclusive classrooms, we're using language that is actually not in IDEA. IDEA says that we need to have students in the least restrictive environment, which should always be in their, we should be starting in a gen ed class, and we know students need support. But when we talk about training for teachers, that is absolutely correct. And there are national experts on universally designed instruction and what it reframing behavior and relationships in creating the right settings for students. But I just want to, I just feel compelled to call it out that we talk about it like it's this new thing or it's not done, but all students with disabilities are general education students and should be accessing education in the least restrictive environment.
Okay, thank you, Christy. Least restrictive. Thank you. Anything else on this one? Okay. Nate, I'm just reading your comment here. Okay, most of your background has been around implementing PBIs in several school districts in Oregon. Okay, would love to know a little bit more about that, Nate. Maybe breakout room 2 is going to be for you. Okay, so here are some opportunities to explore. I know the first point is controversial. Fully realize use of MTSS and PBIS and implement it to fidelity. There's a lot we could talk about there. This is just something to explore, something to put on the table. I know there are probably lots of feelings about it. Improve accountability for IEPs and 504 plans. While families are offered due process and there's a whole thing they can do when they have concern about use of implementation of an IEP, these things are lengthy and often require assistance from an attorney, which is just not accessible to a lot of families. Increasing resources for schools. We talked about the special education funding cap as one potential. I know there's been legislative attempts to increase the cap. There's also a lot of opportunity in expanding use of Medicaid billing. Only a third of schools or districts, education agencies, I think is how OHA talks about it, are billing Medicaid for services. There's a lot of administrative burden there, but it would bring a lot of resource for these support services in particular. I think Hillary talked about transitions and the challenges there. So yes, what does that look like? What is the policy? What does the process look like when a child is transitioning from pre-K to elementary, from elementary to a secondary setting to post-high school, whatever that looks like for that young person? And how can we kind of eliminate some of the information and supports that get lost? And then finally, resource family organizations like FACT Oregon and others to really enhance information about school-based supports. Okay. And finally, the third bucket, coordinating with community-based services outside of school. So the MTSS framework delineates the primary responsibility of education systems and their community partners. And in general, schools and districts are to bear responsibility for delivering those foundational supports at the base of the triangle. So tier 1 and then 2A-ish. Community partners, including community-based mental health agencies and others like Fran highlighted, hold primary responsibility for delivering services in, upper tier 2 and tier 3 of the triangle. OHA, I think, has agreed with this delineation, but it's really not clear how and if they're operationalizing this by way of funded entities like county mental health programs and CCOs. So, Ebony, I don't know if there's anything you want to say about that, but that is something we could explore. And just one other note here, ODE did a really nice analysis of integrated behavioral health programs. I think primarily what was being funded through the Student Success Act. And all of the school districts they visited shared their desire and need to provide more supports than what the district could offer. So we've got schools saying they want more support, community providers saying that they also want to be providing more support. And yet we've got a lot of policy and system barriers, many of which you've already talked about today. There's lack of staff and staff capacity within schools to kind of help support these structures. There's lack of physical space in school buildings. Some schools and districts have lack of trust for community providers who want to come into the school. There are school policies that get in the way with respect to allowing providers to come in. Consent and confidentiality concerns. Remy already mentioned the role of FERPA and HIPAA in this work and how complicated that can be. Lack of billing and funding structures, especially for Medicaid. Transportation for specialty care outside of the school setting, especially if it happens during the day. A lot of people understandably have concerns around disrupting instructional time. And then for young people who might need more intensive treatment in a hospital setting or a residential setting, or maybe in juvenile detention for a while, the transition from the education transition from a public school to those settings and then back, there's a lot of room for improvement as well. Anything else people want to name here?
I would just name that in all parts of the state, they don't have the same access to some of those more specialized settings for students who need that, especially when you get, maybe Lane County and South. They don't have access to those types of facilities.
Great. Okay. So the rural kind of geographic barriers. Thank you. That's important. Anything else for the moment? Okay. Again, here's what families shared: limited communication between agencies, repeated paperwork and intake processes, loss of information during school transitions, both I think from elementary to high school, as well as, public education to what I'm going to learn while I'm in the hospital for a couple of weeks. Lack of shared planning across systems. So Alex, kind of to your original point around is there one care coordinator who's doing all of this? No. And the fact that effective coordination, when it happened, was driven by individual relationships rather than established systems. And Remy, I see quite a few barriers that ODE is changing. Yes, thank you. There are lots of opportunities to explore here. Implementing MTSS to fidelity, and really making sure that schools and districts are supported and communities as a whole are really supported. Providing simplified, coordinated, transparent systems that are easy to navigate, centralized access to clear information, family navigation provided by peer supports, encouraging use of shared care plans. This links to one that Ocean provides. It's a nice example. There are others. Expanding use of Medicaid for delivery of school-based services, and utilizing billing hubs to support schools who have limited infrastructure to do that because the administrative burden is a lot. Standardizing policy and procedure for youth transitioning in and out of school. I know that the Tri-County System of Care is actually working on a document like that this summer, and maybe that's something that could be rolled out to the rest of the state. And Remy, do you want to name anything else here? I see your hand is up.
Yeah, I just wanted to share really quick that there are some changes going on at ODE that are by no means quick fixes, but let's think decade. Actually, no, I'm lying. Actually, because the special education, one of these biggest barriers is like, God forbid, a student wants to switch school districts for some reason, and the documentation it just burns as soon as it exits the barrier of the school district, and that leads to a lot of difficulties for our children and families and like trying to access the best level of care that they can, right? And one of the big fixes that's actually like on the horizon at ODE right now that I can't remember if we've talked about, Christy, I don't know, maybe I have. The special education team is setting up a statewide data system for special education students, which is cool. And then on top of that, ODE actually got a legislative mandate and funding to do the same thing for all students over the next decade. So right now, the first thing that'll happen is a statewide student data sharing system for children in special education. And then the next step that's going to be built over literally the next decade is a statewide student data sharing system for all students, so general population. So that's pretty cool.
Yeah.
Yeah, and that's one thing I wanted to share. And then the other thing, I see expand use for Medicaid for delivery of school-based services. Just noting that like that's something that my team is actively working on with our partners at OHA. And that's another thing in this accountability implementation, the Senate Bill 141, which is really big in our education system. A lot of changes. And whenever you hear me say, like, we actually have the opportunity to make some changes in the education system, that's what I'm referring to, Senate Bill 141 from last year. And what I think is really cool is that Medicaid, Medicaid can cover all services for EIECSE, right? And all the different supports for through IDEA and like IEPs. And a lot of schools don't do that, like you said, Christy. But what's really cool is that my colleagues are working on these documents on how to leverage Medicaid in these like larger ways. So we're framing it as like, yes, there is an administrative burden to setting up this Medicaid claiming system, but you can fully support your kids on IEPs. You can start offering prevention services for suicide and substance use prevention. That's all funded by this Medicaid claiming system that is like fairly self-sufficient once you set it up. So those are two things that are like actively rolling at ODE. That like I'm not going to say we wouldn't take help with, but just so you know, like that's those are two cool developments that are happening in my neck of the woods that y'all should definitely be aware of. Thank you.
Thanks, Remy. All right. Okay, I'm done talking. So we're going to get into some breakout rooms. You get to choose. You can go into room 1 if you want to talk about timely access to assessment and evaluation. Room 2, delivery of behavioral health supports in schools, what happens in the school building. Room 3, coordination with external community supports. Your task is, what is one action that you think the subcommittee, council at large should take to address some of these concerns, right? We're not going to get to everything. There's a lot that's already happening, but where could System of Care Advisory Council play a role in like addressing a gap, bringing together cross-sector partners where needed, consider things that are, have impact, are also feasible. That's the discussion I'm hoping you can all have. Does that make sense to folks? Anna, can you put together some breakout rooms?
You want 3?
Yeah. And while you're doing that, I saw a hand up for a second. I don't know who it was though.
I did. I put.
Oh,
Excuse me. Hi. I did put my hand up for a second, but then I was like, it's okay. But what I was just going to add on that last list of, I think it was potential resources or whatever that last slide was titled. There is a program that Youth Rights and Justice, which is a legal advocacy firm in Portland, has the School Works program, and it's specifically for the lawyers to help the youth who are in foster care and making sure they're getting the right educational supports, whatever that might mean, access, support, assessment, planning, whatever. So it is, it's a limited model because they are Portland based. So it's not like they can do it statewide, and it's not a huge program, but it is kind of an interesting approach where those lawyers can come in and kind of serve as advocates for the youth to make sure that they're getting what they need.
Great. Thank you. And Anna.
Hi, just a quick question to differentiate group 2 and group 3. I'm trying
Mhm.
to figure out if you're talking about partnering with behavioral health agencies in the community about supporting young people in schools.
Mhm.
Would that be group 2 or group 3? Or both?
Yeah, my gut is to put that in room 3, but I think it could happen in both places. So
Do you want me to title the rooms, Christy?
yeah. Well, if you can,
I can. What do you
or
want
if
room
people
one?
just know, room 1 is a timely assessment. I'll put them in the chat too. Room 2 is supports in schools. Room 3, coordination with community supports. How about that?
Okay. And room 3. Okay, and then folks can just choose which room that they go in. So you will see yourself saying unassigned. You'll need to scroll down and select timely assessments, supports in school, or collaboration with community supports, and click the blue button that says join next to whichever room you want to go in. If anyone is having a rough time, go ahead and raise your hand and I can assign you to whatever room you want to go to.
Sorry, I maybe missed that first instruction. Where was the room button?
Do you have like a thing in front of you, like a breakouts thing in front of you somewhere?
Do not.
Weird.
Alex,
Okay.
there might be
Room
a
do you want to
more
go to?
button
I
at the
can move you
bottom,
into it.
Oh, more.
and then
Join
join a
breakout room.
breakout room should be in there.
Appreciate it, Cody.
No problem. Christy, what would you like from staff to help support here?
Oh,
Do you
I
want me
don't
to just
know.
pop in a room or?
Yeah, I might just pop in a room. Are you gonna go into a room, Anna? Are you gonna stay back?
I was gonna stay back just in case because sometimes people hop out or people join or whatever and it's awkward. So if you two can
Yeah.
hop in a room, then I can stay back. Christy, I think you're better in a room than I am in terms of being the thread.
Okay, I'm gonna go to community supports. Timely assessment has less people, but we connect with Ocean on the regular, so we can connect with them later.
Okay. Hillary, do you want to go
And
into a room? Cody, do you want me to send you somewhere?
Yeah, I ended up in the same room as Fran, so I'm going to change rooms. So
Got it. Okay.
I just have
I was
to
just checking. Oh,
get my act together.
Okay. What do you need?
and I was just checking to make sure that each room actually had the instructions because sometimes the chat goes away, but I think it'll be okay.
Oh, what time are we supposed to come back?
Ooh, I don't know. Let me pull up the agenda.
That's fine. I can do it. I got it. You go in your room. I'll
Oh,
figure it out.
all right.
Bye.
Go to your room.
Go to your room, Cody.
Okay, I'm on it. I'll join timely assessments. There's only 3 people.
Thank you. And I'll pause the recording. Okay, people are just about to say the most interesting thing they've said all day. And the breakout rooms will close while they're in the middle of it in 5, 4, 3, 2, 1.
You have so much power.
Is the most interesting thing that could be said was there's no problems at all. For a multitude of reasons.
I don't think anyone said that, Alex.
If they did, that would be interesting to me. So
That would be fascinating. Hey, everybody, we were just Alex, Cody, and I were in this main room a little before the rest of you. So with 10 seconds left, I said, and the most interesting thing anyone has said all day is about to come out of their mouth, and then they're going to get interrupted when they all get whooshed back into this meeting. So hopefully you had good conversations. Christy, I don't know if you want to facilitate the report out or if you're hoping for.
Yeah, I sure can.
That'd be awesome.
So we only have a few minutes. I think we got to leave room for a little public comment. So I'm going to ask whoever's reporting out to I'm sure you talked about more than one, but give us your top 2 takeaways, let's say. You get 2 minutes. We'll start with room 1.
Hey, this is Alex. I'm going to stay off camera. I just had kids show up early and water heater taken care of. So I'm here, but I'll do a quick report out about the 2 we talked about. I think the most was potentially talking about the solution of EPSDT paying for case coordination or navigation services, as you mentioned previously, Christy, and navigation to help them go through this process of multiple system involvement, filling out eligibility, so forth, being that third-party advocate that's not tied to the system's success or not, but simply the family's success. But we also noted systematic or policy problems pertaining to how the CCOs operate EPSDT and how OHA believes EPSDT should be ran, and the device seems to have 2 extremes of CCOs denying claims and OHA having a thought process that many things should be included within that. So there's cross-system decision making that doesn't seem to have clear coordination, where these kinds of unique solutions that come within the system could be considered potentially. Also, you have to be a behavioral health certified, have your COA to charge for EPSDT services with an enrolled eligible behavioral health youth, which also creates a barrier, right? So there's no independent case coordination to help families navigate and assess and enter these systems so they can get support. But maybe there's a system, once that's done, they can take on that role for navigation supports, which would be interesting because I know there's been a lot of work on traditional health workers with peer systems to authorize that pre-work and support of families, but no connections to families, education, and disabilities yet that we know of. The second was as to potential low-hanging fruit, and I believe, again, something not so unique, but you mentioned it a little bit about education. Knowing that these youth heavily go through behavioral health and may see a psychiatrist or 2 on their way up into the system before eligibility is determined or a concern around disabilities occurs. And this may be more of a specific knowledge piece to myself, but in talking to a close associate who's a psychiatrist, he spoke about this gap significantly, that the education and licensing boards don't require many trainings or continuous education units pertaining to disabilities, diagnostics, assessments, or so forth. And so it wasn't part of a standardized training that psychiatrists, particularly child psychiatrists, receive. And it's elected as you go on. And the core material that I think he said that they did provide, and I don't want to be the complete knowledge and repository of his truth on this, is it was minimal in nature. And that he has been identifying this as a growing concern of children who've been multi-system involved, usually entering the justice system because they're labeled behavioral in some ways, senses that he's seeing them 10 years after multiple psychiatrists and identifying a disability need. And that's only after significant geographic displacement of services.
Interesting.
So
Okay,
that's 2 great, Alex.
solutions. Yeah, EPSDT and looking at what kind of training and support psychiatrists get around.
Yeah, or requirements around their licensing boards and CEUs.
Yeah, great. Okay. Let's move on to room 2.
I popped it in the chat, but we had a lot of conversations around the use of peers in school. And so literally student to student, but also how do you get youth and family peers? Courtney was talking about, in every conversation and you ask someone what do they want, they actually want a peer. They don't want another counselor or another whatever it is. So how do we actually flip the system so that that happens for folks? And then the other one around training was it's so hard to get training to teachers these days because there's no time, everything's being cut. We need to do a better job of training our trainees. So how do we get more brain science into those young people as they become teachers? And I think at the moment they get like 4 hours in the whole class was the last time I heard a quote on that. So how do we up the mental health education so that they're coming in ready to handle what they're faced with? And then the final one was the importance of the transition from childhood into school, and so many young people who come in with deficits. That whole piece just leads to issues for the kindergarten classrooms, people not ready to learn and have had no training. And I hope I represented that well, Jared, but that whole piece about how do we increase the effort around that transition so young people are able and ready to learn and emotionally able to regulate in a classroom.
Great. Thanks, Hillary. All right, lastly, room 3.
That was us. I think that were you taking notes, Kristen?
I took notes, but if you want to report out, that would be great.
Oh no,
You
I'm gonna
didn't?
let you go.
Do you want me to?
Yeah, I'm
Okay,
gonna
I
let you
think
go.
I'll get us started. We talked a lot about FERPA and HIPAA and how that is like a major problem for working with community providers. Sounds like ODE is already doing some of this work, particularly with ODDS, which hopefully will ease the problem, at least for kids eligible for those services. Sounds like MOUs might be kind of like a way to smooth that. I think there's also a question around feasibility of addressing that particular area, given FERPA is a federal policy governed by a federal Department of Education that may or may not be around right now. Who knows? The other thing we talked about was provider literacy. Again, kind of like training providers, making sure they really understand the various services and supports that are available, that they speak the language that schools speak. A lot we could do there, Fran, if I'm going pretty quickly here, but if I miss something there. And then we started talking a little bit about care coordination and what it might actually look like to create like the one person in a community who can walk alongside a family in all of this with a real shared plan. Ebony was telling us a little bit about what happened when they tried this in the adult system, and then we unfortunately got cut off. So anybody else want to add from the room 3? Okay. All right, we only got a few minutes left. I know there's a lot more conversation. Again, this was just the beginning. But what feels like a good next step here for the committee? Is there a particular topic area that are people like, yes, that's the thing we can work on? Do we want a little more time to explore and think about it? Is there a work group that people want to form to kind of flush this out a little bit more? What do folks want to do from here? Remy.
I do think I don't want to try to make a decision for the group or anything, but I did think that the idea of diving into that question of case management is really interesting. I know I'm a broken record on this, but it's a lot easier for y'all to get your local systems of care to interact with the school districts than it is for me to do it the other way around right now. Once again, I am trying, things are coming, they're going to be a little different, but only a little different. It is so much easier to get CCOs to interact with the districts than it is the other way around. And I think the idea of a case coordinator for a student moving through all these different systems is really, really interesting. And I also have no idea where that onus with land. And like that is the nexus of the accountability bill in the education system that just passed. A lot of hot potato with our kids who are being served by our multiple systems. And I just think that's a really interesting question to unpack. It also makes me anxious just because I'm like, oh my God, I have no idea, which is also why I think it's a good idea. So thank you.
Yeah, that's great. And I know, Nate, maybe this is what you're going to talk about, some of the work that's going on with IHN and Lynn Lincoln Benton, or something else.
Kind of in a way. I would it would definitely involves that. I was just going to share in terms of something to focus on or potential work group or anything. I'm certainly biased because I do youth peer support, but I feel passionate about it. I feel like peer services, if we're looking at like true systems transformation, if that's the number one thing that I don't know if I would, depending on the data source, but at least from the data that I have and what's been mentioned in this meeting, like peer services being one of the things that can be the most drastically supportive, and especially if it's really not integrated, at least widespread in the state. So yes, not to my understanding, I don't really see it much. But looking at the mechanisms to do that, putting together a work group to have more conversation on that, or whatever capacity that would work. I was just going to throw that in. And then that second piece, just Remy, what you were mentioning about having someone to come alongside a young person and or family around, like, while they're navigating different systems, including the education system. It's actually, I would be happy to share a little bit more on that at another time when we have more time. We are implement through the youth council I coordinate. We are implementing a youth peer advocate like program service within it. It's low capacity. We're doing our best with what we got, but that is the intention behind it, and kind of have a whole system built for it already. So yeah, I would love to connect more on that.
Very cool. Thank you, Nate. Alex.
Yeah, just quickly, I would happily join any work group about case management. But one of the points we talked about in our group, that's psychiatrists and their continuous education mandates and so forth. I truly believe this is a low-hanging fruit system-wise. Doesn't require massive policy, or it requires some mandates, of course. But I think it's a larger conversation for a lot of the goals of SOCAC. And I would have us all think about what if child welfare and OIA, juvenile justice, were required to take suicide prevention training as part of their job positions. Is there a state standardized training that case managers and those who interact with youth could better assess them, including disabilities or identifying these things earlier? We don't provide that as a government in a state. Much of the training within state agencies, there is some slight curriculum curation that's chosen by the state. The mass majority is chosen by state. There's some that's demanded federally, but there's no discussions about what people should have qualifications and backgrounds and continuous education about. But we do have those standards for therapists, for instance.
Yeah, I can follow up with Kyle Johnson, who's the child psychiatrist on the SOCAC. I'm working kind of like a memo that summarizes kind of all of this information, and I sent it to him, to our new school, our new psychologist and our pediatrician. Pediatrician went through it and had some really interesting things to add, but I will follow up with Kyle on that and see what he thinks. Alex, thank you. Leah?
So I just want to say, first of all, this has been a great conversation, but I also want to throw out there that I learned these really amazing terms today in another meeting, microwave thinkers and crockpot thinkers. So I am a crockpot thinker. I need time to just like marinate for a while and like let it all heat up, and then I come up with this really amazing thing. I'm sure there's a ton of microwave thinkers in this room, and that's amazing. I think that this has been a lot of information, at least it has been for me. And I've been, seeing it now for a few weeks. I would love to take these ideas and have time to consider, like, what can SOCAC actually bite off? What can we chew on, and come back and, or even have a conversation offline, like, whatever. But I feel like I need more time, and that may just be me. Maybe maybe this whole room is nothing but microwave thinkers and I'm the only crock pot in the room. But
no, Leah, I just want to say that I appreciate that. Sorry for jumping in. And I also think that being able to take time to think about kind of the ecosystem is going to be important, just because I think we would be remiss if we're not also thinking about the current challenges in climate that we're having to navigate as a system, and seeing kind of, system, contracting as a result of dwindling resources and increased need. And so, whatever we propose, we got to think about the sustainability, and it's going to be complex. And so I do think it is beneficial to have a second to, to kind of think about those contingencies as we make a recommendation.
For sure. And I mean, not to say I love the idea of having some like if we identify, a few spaces here, which it sounds like we have at least 2, maybe 3 that we are really, really passionate about, having some work groups. I love that idea too, where we can really drill into these problems and come up with hopefully some cool ideas. But yeah, I think I need time to personally.
I love this idea. And if it's helpful, I could kind of take those, whatever, 6, 7 things that you all pulled forward from your breakout groups, not to be like exhaustive, right? Not to limit us to those things, but I could do a little bit of thinking around like, well, what would the impact be here? And what is the feasibility of actually doing something around this? And we could bring that back to you all for some more informed conversation, if that would be helpful.
That makes sense to me. And then, Christy, maybe we can get that to chairs, Clark and Tucker, and they can think about how they want to flow this in. The next meeting's agenda was to sort of finalize next steps, so it fits in already sort of with the arc we had planned. And then we have a little bit more time here to think about this in this space, and also for other folks to kind of weigh in, and do please, for the rest of the committee, feel free to email me. We avoid serial communications by not emailing everybody, but if you have thoughts or ideas that continue to percolate as your crock pot brain continues to stew on this, do feel free to just say, oh, and another thing, or I wanted to add some context to that thing, or whatever it is. And I'll make sure that Christy flows it into the memo so that we have a robust discussion based on this conversation at our next monthly meeting. Does that feel okay for folks? Okay, and there wasn't anyone here who wasn't here to participate in the conversation, so I skipped the public comment section, but I do, if there's 1 minute and somebody wants to say a thing. Public comment wise, now's your chance. Okay, next meeting is also Zoom.
22nd at 3 o'clock.
July 22nd at 3 p.m. Thanks, Chair Clark. Appreciate you. Thanks, y'all.
Everyone.
Bye.
Thank you.
Anna, I do have a question if you have just a second.
Sure.
I was looking. I'm sorry, what?
Let me just stop the recording.
Oh, okay.